Our next speaker
Nice work,
is
man.
Dr. Kuang. He's going to talk about man versus prostate, better bladder baseline.
Just this one.
That big green one.
All right. So my objective today is really quite simple, that there is a path to a better BPH care pathway, and it really starts with a better bladder baseline, where we can stratify patients based on how at risk are their bladders for death and dysfunction, so that we can act with an appropriate sense of urgency to de-obstruct prostates and stand firm against the polypharmacy epidemic. Let's get these guys off meds, minimize meds, or not even have them started at all. And my promise is that together, we can affect positive change away from a drug-first approach to a data-first, bladder-centric, pro-diagnostic paradigm, so that guys can prioritize bladder health while making the best decision possible for their prostate care to live a life well-lived, chemical-free and catheter-free. Disclosures. As physicians, we have strayed too far from our Hippocratic oath. We've become so fearful that we are going to harm a patient by doing something that we should not do, surgery, that we have lost sight of the fact that we can equally harm someone by not doing something that we should do, like intervening to prevent bladder death and dysfunction before it is too late. Yes, it is goofy that we've just been taught to reflexively prescribe medications instead of getting that baseline assessment of bladder health up front and early. Have we been negligent in our duties as defenders of the detruser with our cystoscopic swords and our pressure flow shields as we let bladders get hurt and suffer on our watch? And have we been turning our backs on bladders as we, put little pretty pink feathers in our hat every time we write a script and a refill under the guise that we're doing no harm? The bladder needs more attention from us. The prostate has been hogging the red carpet. It needs to allow the bladder to share some of that spotlight. There's only two main organs that cannot be transplanted, right? The brain, makes sense, and the bladder. It's that amazingly complex. It cannot be transplanted. It is that precious. It is one of a kind. We need to take better care of it. And I get it. Back in the day, invasive surgical therapies had complications, morbidity, mortality, and as a result, we leaned on medications because they had a perceived, more favorable risk-benefit profile. And so we leaned on this industry at $4 billion a year, and it rose and escalated in the 90s and 2000s, but we got into a bad habit with this polypharmacy epidemic. Got a problem? Take a drug. Still got a problem? Higher dose. Still got a problem? Hey, take a second or a third drug. We need to stop that. And this is something that we should do and will do, but not just because we want it. It's because our patients want it. Our men want it. The modern man wants it. 2/3 of men on meds are not satisfied. 2/3 want an alternative to medications. We espouse holistic care, being minimally invasive, yet we prescribe medications which are maximally invasive, touching every single cell in our body, creating an environment of holistic toxicity. I mean, this is the litany, right, of all the side effects from these medications. Probably the one that scares us the most is, for me, post-finasteride syndrome, that has its effects long after we discontinue that medication. So it's no surprise that guys are saying no to a drug-first approach. Yes, low compliance rates. What, 29% of guys are still on meds at 1 year, 13% at 4 years? The systemic side effects affecting adversely cognitive, mental, hormonal, cardiovascular, sexual health. And yes, the cost and inconvenience. And all for what? A marginal improvement of 5 to 7 points on the IPSS versus what, 4 points in placebo in the MTOP study? We can do better. Of increasing concern is the emerging data that perhaps moderate and severe lower urinary tract symptoms is associated with an increased risk of death. I think urge urinary incontinence in this study had the highest association with a hazard ratio of 2.9. And that's for a symptom that we don't even cover on the IPSS. If subsequent studies reveal this to be true, we have even more reasons to be better and do better for the 42 million men in the United States, at least, that have BPH, of which half have moderate to severe symptoms. Only a quarter, 12 million, are going to be going to see a urologist or seek help medically for their BPH. Sadly, only 53% of them will follow up. And we urologists share in that responsibility because 7 to 12% of urologists allow them to move on, only move on to diagnostics. So 90% of guys, urologists, let their patients out the door without any diagnostics. And we look at those 12 million men, what happens to them? Well, the bulk of them, 64%, fall victim to the polypharmacy epidemic and get prescribed a drug. 34% are then put on a plan of watchful waiting with no strategic mechanism to survey bladder health to see if it's progressing or deteriorating. And what are we waiting for? For them to show up in the emergency room on their 2 BPH meds and retention with 2.5 liters in their bladder, or refractory, irreparable bladder damage? We can do better. And so let's stop pretending, right? Say no evil, see no evil, hear no evil. We are doing harm with this current paradigm of a drug-first BPH care pathway. Let's stop muzzling the bladder, the amazing untransplantable bladder. Let's stop relegating it to the nether regions of the pelvis like a redheaded stepchild. Let's stop silencing it with medications as we let the bladder damage ensue. Pivotal study, 2020, 50,000 pressure flow studies. And what we found, as you all know, and it confirmed what we all suspected, right? In the bottom right hand, as men age, as expected, the prostate grows tighter, that prostate donut hole is going smaller, and Qmax, maximum flow rate, decreases. And as expected, initially the bladder has to work harder in the upper right-hand side, and as those pressures, it secondarily has to generate higher pressures until about the age of 62, at which now the bladder function begins to deteriorate. But this is nothing new. Tubero in the bottom left-hand corner, he said in a paper in 2003, early treatment of BPH has implications for reducing the risk of permanent bladder damage. This was 20 years ago, and we have still not changed our paradigm. He knew this because in 2001, he did simple prostatectomies, and despite 100% deobstruction, only 61% had complete resolution of symptoms. And then Young in 2000 looked at TURPs in 1990, 2000, 2010, and as expected during this time of the polypharmacy, medications increased, TURPs decreased by 64%. Of more concern was the number one indication shifted from treating symptoms to retention. We were waiting too long. Diagnostics and therapeutics continue to change rapidly, but do you know what's rapidly changing even faster? Is our patients, our men, the modern man. They want their own data. They want us to share their biometrics with them so they can make the best decision even better, even faster for their bodies. They want us to make the invisible visible within their pelvis, specifically their bladder health. So yes, to get to a better bladder baseline, we need to shift to a data-first, bladder-centric, pro-diagnostic pathway. And now is the best time for us to be doing it in this golden era of BPH, right? Soon we'll have transabdominal ultrasounds of the prostate with 3D reconstructions. That's right on the horizon. Cysto with high def, 5K, imaging, plasma screens, pressure flow data that's easily obtainable. And together with these tools and techniques at our fingertips, we can now create and peer through a window, a conceptual window of curability. So I took that data and I overlaid, just using some basic age cutoffs of 45 years, a flow of 10 cc's per second, and magically this red window appears through which, if we can intervene through that, can we do it before the onset of bladder damage or before the damage is irreparable? So yes, time is running out for all these bladders of the now and the future that will be on medications that are being muzzled, and we are so much more than just de-obstructing surgeons. We are preventative interventionalists. Like the oncologist, early detection can lead to early intervention, saving bladder lives. So if you look at the current guidelines, Part 2, 2021, it states here the primary goal is to alleviate symptoms. Is that a bar that's high enough? It minimizes all that we know, all that we can do, and all that we should do. Perhaps it should be something like this: a higher, more loftier bar that's inclusively improving symptoms, but prioritizing what's really important, is that detrusor function. So when we look at the guidelines, again, Part 1, we are not just treating LUTs, we are not just treating symptoms. Yes, there is a huge elephant in the room and we dance around it. If the PVR, where the asterisk is greater than 300 cc's, get concerned that the bladder's dying. And at the very bottom with the X, no, let's not default men to a trial of medications. Let's default to a data-first pathway. Let's get a bad risk stratification, bad standing for bladder assessment for death and dysfunction. So once again, yes, it is the basic management for preservation of bladder health in men. And instead of going and defaulting reflexively to medication, let's get that bad risk stratification using qualitative data like cystoscopy with trabeculations and or quantitative data, pressure flow data, non-invasive or not, and begin to act accordingly. As urologists in the academic community needs to guide us, set up those guardrails. I get it. Community urologists, we need to educate our men with what's at stake. You know, for man versus prostate, it's the 5 stages of bladder health. Everyone's got their techniques and tips and talk track, but it's important we get that out up front on that first consult and be defenders of the detrusor. Get that better bladder baseline to help our men make the best decision even better. So please pull out your phones and text the next number. That's the man versus prostate number. So we can send you PDFs with educational information to help you, your team, your patients get to that place where we're preserving and saving bladders together. Because yes, it is goofy. If we continue to do what we've been doing, it is possible for us to do so much more, because we are going to stop turning our backs on all the bladders and we are going to lean into the responsibility of protecting detrusor function so that we can be defenders of the detrusor and guardians of the bladder. As you guys know, Susan G. Komen, Pink Ribbon, breast cancer awareness, nothing like that has existed until now for bladder health and BPH patients, using AI newsletters, geofencing, educational push systems, so we can take care of this problem, straighten it out, increase awareness. It's long overdue. We can do this together. Well, it's been fun and fascinating. Fun to hear everyone's perspectives, and been highly stimulated and provoked by the perspectives and questions you guys have had. It's been great, and I look forward to doing it again.
Thank you very much.